Hey guys, I'm gonna do a little video here about the different types of small volume nebulizers. So we finished talking about bland aerosol and large volume nebs, okay, filled with a lot of times we're dealing with a 500 mil all the way up, a liter type of fill volume. Small volume nebs, much smaller. We're going to talk about some of the different variants. So small volume nebulization is generally for the administration of medicated aerosols. Okay, we're going to talk about some of the most common ones you're going to see kind of in our clinical area and in clinical practice. We're going to reserve continuous nebulization for a different kind of topic, okay, or a different video. So we're going to focus on really two different types of small volume nebulizers, and a lot of times we just call these first ones jet nebs. Ultimately, you guys know what a jet is, okay? It's taking a gas stream, sending it through some sort of a restriction, and on the backside of this restriction, things open up wide, and that gas can speed up. As that gas speeds up, it creates this lateral pressure drop, right? In the large volume neb and the Venturi type stuff, that lateral pressure drop was pulling in room air. On these nebulizers, okay, ultimately we're using that lateral wall pressure drop to effectively pull liquid that's in the bottom of these reservoirs, pull it into the suspension and place it into this gas stream, okay, and create aerosol. So aerosol, just these little medicated particles suspended in a gas, so we can ideally most of the time target deposition down into your lower airways. All right, so let's talk about some of these different little. Sorry, it's kind of warm today. I got bees and wasps and stuff coming out of the woodwork out here. So let's talk about two of the kind of most commons. I'm going to talk about some of the parts on them, and I'm going to talk about the different hookups here, okay? So we call these just regular jet nebs, all right? These are the standard, been around for a long time. I often slang-wise refer to this particular one with kind of the blue piece that we're going to talk about here in a second. I call this the Misty Max. It's still a jet neb, nothing special or anything. It's just what the actual order is when you order these. These are Misty Max nebs. Okay, both work the same. They have the same similar parts and everything like that. Just a little bit different. I don't know. Playing with them in lab, I feel like these Misty Max are even a little bit better than this one here, as far as what it seems to be, aerosol output, the amount of aerosol being emitted from the device. I don't have any data to back that. Just one person's kind of opinion here. So one thing I kind of want to point out is all of these jet nebs are going to require some sort of a compressed gas, okay? Doesn't have to be oxygen. We use oxygen a lot of times at the hospital, but we're not giving these treatments in order to improve somebody's oxygenation. It's to reverse some sort of potentially or hopefully reversible airway obstruction, so bronchospasm, something along those lines. Sometimes we're depositing upper airway stuff for like racemic epi or something like that. But we need a compressed gas source, okay? Now, I always try and steer you in the right direction. If you look, this particular one, this Misty Max, you can see we got a spot that would accept oxygen tubing here, okay? There's four other little pieces here that I could put oxygen tubing on, but these are just the legs of the nebulizer allowed to sit upright, okay? I have literally failed people on this competency for sticking oxygen tubing onto these legs and wondering why they don't have any aerosol. So we need gas to go right into the center of this thing. The other one doesn't have that problem. It's only got one piece where you can hook stuff up, okay? So not as likely, but still could happen. Now, as far as I don't know if you'll be able to see this. You'll be able to see it in class. You'll see there's markings on all these nebs as far as the volume. That's so we don't have to necessarily measure things out. We can eyeball it. Often we do measure things out. So you can take a look and see how much volume you have inside of these things. So for standard nebulization, our goal is generally to get a total fill volume of about 3 milliliters, okay? That makes a sufficient amount of these doses of most of our medications respirable, meaning we're aerosolizing them and making it available for the patient. If I only squirted a tiny little half mil or 1 mil or something inside of this thing, there's going to be waste, okay? There's going to be residual or dead volume that stays in this nebulizer at the end of the treatment because it's not able to be pulled into suspension. There's always going to be something left. So by adding normal saline, or sometimes you'll have some of the drugs come pre-mixed for a total volume of 3 mils, by getting a sufficient total fill volume, we're actually making more of that medicine available to that patient. Okay, the term diluent gets used. Sometimes we're adding saline and we're diluting it, and effectively we are diluting what's coming out of the nebulizer, but by mixing it in with this diluent, it's making more of that available. So the stuff that's left, or the things that we're wasting, ultimately are going to be in a lower concentration than if we just were shooting in pure drug or something like that. So actually, by adding more diluent, you're making your patient get more of your medication. All right, and that's something we can keep talking about in class. People don't understand this. Sometimes I've worked with some people and they're like, oh yeah, they're having a lot of side effects. Their heart rate was going up with albuterol, so I gave them a little extra normal saline. I filled up with 5 to dilute that down. Well, yeah, what's coming out of that is a little bit weaker, but you're actually making more of that, standard 2.5 milligrams of albuterol available for that patient. So likelihood is you're not going to get any more therapeutic effect, but you're more likely to get more side effects. Okay, so something that we can keep talking about in class if you're having trouble. All of these usually have some means of being able to twist the top off. Okay, um, this little plastic piece is very, very important. So if you look, there's our little jet there. You can see that little nozzle. Things come on the back side of, go through. There's a little pinhole right there as well. Comes through that opening, all right, and we end up with this lateral drop, okay? What we're doing is pulling some of that medicine up and into this, and it gets pulled into that gas stream, okay? And that's how we're creating an aerosol. So that little lateral pressure drop is effectively pulling medicine up through this cup and going to be responsible for creating our aerosol. So if you look at these closely in class, you'll notice that that little blue spacer is not completely tight on this little centerpiece entirely. There's potential space. That medicine gets drawn up through the sides of this and gets pulled in the gas stream right there. You'll notice as that medicine goes through, there's a giant plastic piece, okay? You might go, well, why would I shoot medicine right at a big plastic piece? So effectively, we have a baffle. So a baffle is like a big barrier that doesn't allow bigger particles to go past it. We only want stuff coming out of this nebulizer that has the characteristics of being able to deposit in a patient's lower airways. You guys will get into immense detail about, optimum particle size and things like that. Or bigger particles, we would rather them hit that baffle and drop back down into the medicine cup and have a chance of being made into a smaller aerosol particle rather than being emitted by the device and having no chance of getting actually into the patient's lower airways and depositing your upper airways, things like that. So all of them have a baffle. Some of the baffle designs are a little bit different. This one is built in the little sleeve that goes over that center post here. Okay, screw that back on, make sure it's snug. Now, as far as putting medication in them, you can squirt it right in through this thing, okay? You can open it up and spray it in. It doesn't really matter. It is important to know how to take these apart because we're going to rinse these with a sterile water, at least per CDC's guidelines, afterwards and allow to air dry, okay? That doesn't always happen for whatever reason in clinical practice, so at a minimum, I'll open this and I'll knock off the residual and allow the thing to air dry. But ideally, you should be rinsing these with sterile water post-nebulization. So got that one here, the original Misty. This one, same deal. You can see my little piece here. I got my jet, this big plastic sleeve, but it doesn't actually have a baffle built into that. Okay, you're going to make sure that kind of clips down. The baffle right here is actually built into this top little lid on this nebulizer. Okay, so we're going to kind of thread that in. Now, let's talk about how we can give these, okay? Our preferred way of giving inhaled medications to a patient is capable is through mouthpiece, all right? So, obviously, doing it with a mask, I'll show you how to hook that up, can be more comfortable for a patient. If somebody's in distress and they can't, breathing through their mouth or something is giving them a lot of trouble, I'll do a mask, or somebody can't seal their lips or you're not cooperative or something's going on, okay? So we got to know how to hook it up with a mask. My goal is to get you doing a mouthpiece treatment when possible. All right. So for both of these jet nebs to do a mouthpiece treatment, you're going to need some other parts, okay? Now, the nebulizers I have here, so that you'll see this Misty Mix, you may not see this green one here. It's got a very unique T-piece, okay? And we talked about T-pieces before. This T-piece is always going to go on top of your nebulizer, okay? So where all the aerosol is going to be emitted from. This T-piece is unique in the sense that it only has a 22 OD adapter on one side and not the other. So on these, there is a right and wrong place to put your mouthpiece and your corrugated tubing. A lot of them have a standard T-piece with a standard 22 millimeter OD adapter on each end, so it's interchangeable. So if it's not going on one side, flip it, and it's going to go on the other. So just kind of show you, I go ahead and have my medicine in here. I got my T-piece, all right. So, I'm dropping stuff here. Pardon me. Oh, I got a spare flex tube. So we're gonna have a mouthpiece. These come in different little variants and things like that. Some of them have like little ribs so it pops in and stays put. You can see mouthpiece doesn't go in this side. Go ahead, push it in. Now, I could go ahead and start breathing on this right now, and I get medicine, but these particular jet nebs continue to elicit an aerosol continuously. Okay, so it's not like it's not continuous neb from the sense of like what we're trying to do for status asthmaticus and giving super doses of albuterol, but it continues to elicit aerosol even in between breaths. We're likely wasting a whole bunch of medicine out of this distal end of this T-piece. So we always incorporate a 6-inch piece of flex tubing that's going to come with these, and this would be our setup for a small volume neb. Okay, so this is going to house everything, all that extra medication is coming in between breaths, and it serves as a reservoir. All right, so likewise, when my patient draws a breath in, they're going to get everything that's coming out of the device. They're going to draw in whatever aerosol suspended in this particular reservoir. This also serves as a point for exhalation. So patient would seal their lips on this, just nice normal breaths, doesn't have to be breathing all crazy or anything. You'll see people doing all sorts of weird stuff with these nebulizer setups. It's really just kind of seal your lips, try and keep your tongue away from the opening. Nice kind of normal breaths. If you occasionally want to take a slightly normal or slightly deeper than normal breath and a slight little pause, that's fine. But these are dosed where you can give it to a patient who's not able to follow commands, and as long as they're breathing, okay, it's going to be fine. We do want them kind of taking sufficient inspiration, so we're sitting them upright, trying to make sure they're taking good breaths and they have their lips sealed. But once again, they don't have to be overly involved. They don't have to be breathing as fast as they possibly can and deep or anything. If we don't want them doing that, we don't want them hyperventilating and causing problems. So that is our setup for this. Okay, if we're doing a mouthpiece treatment, you would do the same thing. Once again, with the little green, nothing changes, just the hookup. Now, as far as liter flow going through this, you can run these. Everybody's a little different. I read the manufacturer's stuff. A lot of these nebs for small volume nebulization would be like 6 to 10 liters a minute. I tend to try and target the middle ground, 8 liters. Some of these nebulizers I'll show you have a lot of back pressure, and you may not be able to get 8 liters, and that's fine. Okay, I know people that run a lot of these nebs all on 6. Now, the faster you run it, more gas going through there, the smaller your particles are going to be, the quicker it's going to run. All right, uh, the slower you run it, longer it's going to take, the bigger your particles. So if I'm trying to target somebody's upper airway, so like for racemic or something, I'll usually run on the lower side of that. But for regular small volume nebulization, for targeting lower airways, I'll try and target like 8 liters a minute. Some of these have a lot of back pressure once again, so if you can't get there, that's totally fine. You're going to see whatever's on that flow meter. All of our flow meters in standard practice today are back pressure compensated. So you might have it set at 8 or trying to set it at 8. It's going to show you exactly what's going through there with these modern flow meters. All right, so that's doing it with a mouthpiece. Let's say a patient is in extreme distress and not going to tolerate a mouthpiece. They're really freaking out, or they can't cooperate and hold it, or something like that. We can use the good old aerosol face mask. So we talked about this with high flow and Venturi stuff. We talked about it with the large volume nebs. I said, really, don't call it a Veni mask, but this is just something that goes with a Venturi. This is a aerosol face mask, okay? So these are set up where this is going to hook straight on like this, okay? And we go ahead, you have this on your patient, and then same deal, we're just having them kind of take nice, easy, normal breaths in and out through the mouth, okay? Preferably the mouth, less chance for kind of depositing in your nares and things like that. And we're going to run on the same liter flow. This is not meant to be high flow. We're just trying to get the first part of that patient's breath they're taking in loaded up with a medicated aerosol. Okay, we're trying to target lower airways generally. So it doesn't have to be a high flow or anything. As far as oxygen, we're giving these with oxygen. It should meet a majority of your patient's FiO2 needs. A lot of times their oxygen saturation goes up, not because of this medicine, it's because we're running with 8 liters of O2. We don't really know what they're getting, but a lot of times, man, you'll see there's probably 40, 50, 60% FiO2, something like that, probably closer to 40 to 50. Okay, so that is not the medicine working. That is the extra oxygen there. So we're not running this as high flow. It does give them a decent FiO2 if you're running this on medical oxygen and everything like that. So that's running with an aerosol mask. Let's talk about one that throws people for a loop. All right, the trach collar. So if I have a trach and I'm wearing this, okay, or maybe I'm even on a T-piece or something, we're going to always use a trach collar for the medication. Not that we couldn't rig this up through a T-piece, like a T-suction or anything like that. We usually switch them over and do an aerosol aerosols through the trach collar itself. Once again, making sure you got this thing in the correct position. So the problem with these nebulizers, we got to be very, very diligent about setting our patients upright. The more that neb tilts like this, even with an aerosol face mask, all right, very easy with the mouthpiece to get that thing to sit upright. The more it starts to go on an angle, the more dead volume, medicine that's going to be trapped in here and not available for the patient, the more dead volume that's going to result. Okay, so we got to try and get this thing in an upright position. A lot of your trach patients aren't going to be able to sit all the way upright. Okay, so it hooks on like this, but your patient isn't going to get any medication. All right, it's going to start sputtering and not giving a constant aerosol and be done as soon as you start it. You'd have to have that patient leaning all the way forward and prone to be able to make this work. Okay, so we need something in order to get this thing to sit a little bit flat. It hooks up like this, but don't do this. This is wrong. All right, so I'm going to show you a couple of things here, okay? Everybody is a little bit different as far as how they set this up. A lot of people are like, you got to be freaking kidding me. This is how you run a neb on a trach collar. I don't like the Misty Max nebs. They're not as good as the second one I'm going to show you here in a little bit. All right, but if you had to run a medicated aerosol to a trach patient using regular jet neb, this is kind of be your options here, okay? So when you get this set up, you'd have your T-piece, your mouthpiece, and corrugated tubing. All we do, all right, is take that package, stick your mouthpiece in, and you can use scissors. You can do this with a glove too. A lot of people do this with a glove, clean glove. I rip my plastic so it's blocking this mouthpiece in because I don't need a mouthpiece if I'm running a trach. I'm going to hook my corrugated tubing up like this, hook my neb up, okay? So right now, if I run this, aerosol would come out of this. It's not going to be able to come out through the T. It's going to be blocked off on one side, and it's going to follow its path through this reservoir, all right, or this corrugated tubing. I could then have this hooked up for my patient, all right, and I could twist and contort. Heck, I could have them hold it like this, and now I can get that thing completely level. All right, I can get it where they can get all of their medication. It looks super hokey, okay? I could rig up some stuff as well if I go down in the department, find some different adapters and start piecing some things together. I could make something that looks a little bit more professional, okay? But this is not just some weird random stuff I do. It's pretty much standard practice if you're running nebulizers kind of like this, okay? So this would be how you do it for a trach patient with a standard jet nebulizer. Once again, just because that thing fits in like this, you're never going to be able to get that thing sitting flat, okay? So by using the T-piece that's blocked off with the plastic and using the corrugated tubing, you're going to be able to effectively give that patient a decent nebulizer treatment and give them a good respirable dose. So that's the three different ways to hook that neb up. Let's talk about a superior neb. Okay, so all of our, not all of our sites are using this, but we get several sites, networks that have kind of switched to these for majority of their patients. They're great. There's a ton of literature backing their use. Effectively can give a much better, more stable particle size and give a more respirable dose in a quicker manner. Okay, in 5 minutes on this thing, patients are going to get a more effective dose probably than, doing a 10-minute long treatment on a regular jet neb. And that is the Aero Eclipse, or we just call these bands, breath actuated nebulizers, okay? So a band is substantially more expensive, but it is better for the patient. They're going to get more of that aerosol, quicker treatment. We're being exposed to less medication, so it's more of a kind of a closed system, and there's less medication waste, right? So let's talk about how this thing works. So if you look, it comes with a mouthpiece built in on it. It still technically is a jet nebulizer, okay? It's got a jet system built in, so we're running this on the same thing. I try and run these on 8. They have a lot more back pressure, so a lot of times you may be able to only get it up to 6 or something like that. I still try and run them on 8 liters, okay? Sometimes you can't go up any higher. A lot of times people will take this off or disconnect this, and they're running their neb on 6, 7, 8 liters, and then they'll see the flow rate shoot up really, really high, and like, oh my god, I was running on 12 or 13. No, all of our standard flow meters are back pressure compensated, okay? So whenever you're running this thing, you're getting as much as you can through it, okay? But the flow rate, say on that flow meter, truly is the actual flow rate that is going through this device. So you can see this mouthpiece, I got a little exhalation port, okay? Exhalation to be huge, so it gas to leave on exhalation as I blow into it, and then when I breathe in, that little flap's going to close down. They come defaulted in the downward position, so because you will get a little bit of residual medication dropping down. It doesn't have to be that way. You can have them going off the top, but it does drip, so that's kind of why it's set. Sometimes if patients are complaining about it dripping on their chin, you can flip it the other way here. All right, so as far as how this works, twist and this piece comes out. You can see our little jet right there, okay? But there's some other crazy things going on inside of this thing that are a little bit more sophisticated. So I still have a baffle. I still got all my regular, lateral wall pressure drop and entrainment and everything. And this is more, I'm shooting these videos from home because I've been out this week and everything, and I just did not have a chance to do any of this stuff before I left. I had compressed gas here, but I don't think I should run this off acetylene or anything like that. It's important to know how you can run this. So the way this would be set up, if I had medication inside of this, and same deal, I got my fill volumes over here, the lines and things like that, you would see, you'd hear gas going in, but you wouldn't see any aerosol emitting, okay? It's because this, we have the ability to make breath actuated or inspiration only. So patient takes a breath in, you'll see this little thing drop down. It's essentially, it takes a substantial, not a substantial, but it takes a little bit of force to be able to open this valve and allow gas to go through this thing. And an aerosol is created. And then as soon as I stop, that little valve closes off and I no longer have aerosol. So I'm only eliciting an aerosol on inspiration. All right, so not wasting as much medication. I feel like it gives you a big burst of aerosol whenever you take a breath in on this thing compared to the others. Very, very effective nebulizer. Okay, so I could just breathe in and out. You can see my little exhalation valve opening and closing. All those things, and some places, man, when these things first came out, we were going, hey, let them breathe on it for 5 minutes and they're done. I'll usually let my patient get their whole medication, but within 5 minutes, they are getting a dose that's comparable to these others. We still use a fill volume of 3 mils, generally with all these, okay, just a much more effective nebulizer. Now, let's say a patient can't seal their lips, or they're having difficulty. It does take a little bit more effort to draw that down. So if you see it's like not really dropping down, or they're having trouble and they're short of breath, you see how that thing's kind of fluctuating instead of, if you look really, really closely here, I don't know if you'll be able to see it, there's two options. This little piece here turns, and whatever line it's pointing to is kind of what's going on. So if you see the little dots, that is breath actuated. It's intermittent, not a continuous aerosol output. It's only going to give medication when they take a breath, and when they exhale, or they stop drawing in, it's going to stop delivering it. If you had a patient we're trying to run it like this. If you had a patient that was taking a mouthpiece treatment and just having trouble doing that, or they're just a talker and keep taking pauses, and you're like, okay, this is taking forever here. All right, let me go ahead and make a little change here. You turn this over to the solid triangle until it clicks, and now it would be continuous. So if I'm breathing on this, you'll notice my little valve is already down all the way. So it would continue to allow that gas to go through and make an aerosol, okay? Whenever I switch that, see the little valve pops open again. So you have the ability to do this breath actuated, which is our go-to, but if you're having trouble, we can go ahead and we can switch this to continuous aerosol output, which you would have to do if you're going to do this with a mask. So some people would be like, well, why would I spend extra money on these if I was going to do this with a mask treatment? That's stupid. Well, no, it's not. It's still a good nebulizer, good respirable dose. And sometimes this is all you have, okay? Now, running this with a mask is very, very tricky. Not tricky, but it's a little bit weird at first because this does hook up, but once again, you're not going to go, all right, sir, take your medication like this here, position them. So it hooks up, but it's less than ideal. Okay, so if we had to run this with a mask, first off, as I put my medicine in, it has to be selected to the continuous aerosol output. If you do a mask treatment on your competency and you do not put this patient on the continuous aerosol output, not only are they not getting the medication, they're not getting gas coming through this, okay, that would be a fail. So it's important that that's the first thing you do, and you make sure when you hook this up, you get gas and aerosol coming out of it, all right? What we need is a band elbow. Now, there's other things that we can use that we can make work. They do make a commercial band elbow, and all it is 90-degree elbow that has the proper fitting. So it gives me the ability to slide right inside of that thing. It gives me the ability to articulate left and right, which is useful if your patient's like sitting kind of semi-fowlers or something, or not quite all the way upright. I try and get them sitting upright, but sometimes you can't. It gives you the ability to get that thing sitting flat so you don't have as much dead volume. And then that just hooks straight onto this aerosol mask here. So once again, let's say I'm sitting like this, and it's like this. I have the ability, all right, to turn this valve. I can make all sorts of articulations, and what you want to see is that nebulizer completely and perfectly upright when you're running it for a patient. Okay, so using the band elbow, you have the ability to turn that thing off to the side. You can do all sorts of things to make sure that it is sitting completely flat for your patient so you don't have any issues. Very, very great. So do that and make sure that you're running on the continuous aerosol output. Now, once again, Triton Collar is a little tricky. All right, so if I have my patient, they're on a Triton Collar like this, I'm also going to show you. You could set it up like this, okay? But most of these patients, it's going to sit on their chest, and you're never going to be able to get that thing to sit flat. All right, so we need some other stuff. Again, I'm sitting upright, and yeah, it'd work, okay? But if most of our patients are sitting like this, there's just no real way you can get that thing to sit flat and stay connected. So you'll see people that are running with the band elbow, and that's fine. Okay, it allows you for most of our patients to be able to make a little bit of manipulation, but a lot of times you have the trach patient that maybe can't cooperate with you really well or anything like that, and maybe can't sit upright. Maybe they got a big chest, and you can't get that thing to sit flat still. So once again, the more volume that is laying in this thing as it starts to sputter and not give us that aerosol output anymore, and the treatment's over, the less of that dose that patient really got. So I'll show you what I do, and I'm a weirdo. Okay, I like all the different little respiratory fittings and things like that. I might do it at first if all I have is this. I can make this work and try and position you and do some stuff and really articulate and manipulate, try and get this thing to sit upright as I can. But when I get a chance, I'll go back down to the department and I'll grab one of these. Okay, so these come in blue color, they come in like a clear color. Ultimately, what this is, it's a 22 millimeter outer diameter, so corrugated tubing to hook to this. All right, likewise, these fit inside of that nebulizer piece, which you might be able to see where I'm going with this. So it's got a 22 millimeter outer on both sides. It's also got a 15 millimeter inner, so we don't need that part necessarily for right now, but sometimes if you're hooking to a 15 millimeter adapter, which there are some things that we will, standard airways and things like that, you got that adapter on the inside right there, okay? And there are some, once again, some things which will use that inner diameter piece. So whether it's blue or white, doesn't really matter, or blue or clear. I put this in like this. Put a piece of corrugated tubing, and then you have the ability to manipulate it. And if that patient can hold it. Now, if they can't hold it or anything, chances are you already have a band elbow, and I don't want to stand there. You can also keep your band elbow so you get a little bit of a left and right, or lateral kind of articulation to be able to set this thing upright. So I got my band elbow in. I can put this piece in. And now, man, I can really customize the angle. I can have all sorts of movement on this thing, and it stays kind of put a little bit better. And I can have it like this, be sitting here. They can still hold it, but if they can't, I can manipulate this thing to be sitting upright because that band elbow gives me ability to kind of turn. I can turn like this. I can do all sorts of stuff. So this whole system serves as a big reservoir going to that patient. And you might be going, well, aren't they rebreathing on that? It's all dead space. But you have gas coming through this at 6, 7, 8 liters a minute, and they're exhaling into this thing. So totally fine, okay? It's not going to be a major problem, and it gives you a better chance of being able to get that patient as much of their medication as possible. All right, so that is an overview of your 3 nebulizers that you could be potentially tasked with running, whether that is, on a checkoff, whether it's on your practicum this semester, whether that's your, first day of clinical or something like that. a lot of our sites are using either the bands and or just the jet neb. And once again, I said three. Really, it's just two different types, right? The jets, the old Misty Max, they come in a lot of different variants, but they all have the same functionality and connections and things like that. So you need to be able to hook this up for an aerosol mask, mouthpiece, and a trach patient. Okay, that's something you need to be able to do for your competency as well as for just general practice as a respiratory therapist. These things can't really forget or anything like that. Okay, so I hope that helps. It's something that generally trips people up, knowing how to hook these things up and how to run them. We'll play with them a little bit more in lab where you can actually see gas going through them and everything like that. And we can talk a little bit more, but I hope that helps.